Welcome back to the Birth Blueprint. I'm Dr. Nicola Pemberton, and with me today we have Chidera Chima, our nurse midwife, and Michelle Gabriel Caldwell, our doula coordinator for the Birth Center in New Jersey.
And Rosemary in the background. Hi, guys.
Hi. Hi.
Hi. So in this episode, it's Black Maternal Health Week.
Yeah. It is.
I figure we can talk about that, right?
We should.
And who better to talk about it with our Black excellence, right? I wanted to ask, what are some of the biggest issues in Black maternal health?
There are many, and I think
just a few, because you know we'll be here all day.
We totally could be, right? But I think I'm just going to rattle off a few. Bodily autonomy, a voice, representation, cultural competency. They're just
bias.
Yeah. Both micro and macroaggressions. And unfortunately, when it comes to maternal health, when Michelle brings up cultural competency and representation, that goes from the level of that practitioner who, as advocates for our patients, Black and Brown alike, they also deal with those same biases, trying to advocate for those patients. So for both midwives, when it becomes nurses, whether it becomes physicians, just saying we're going to be the ones representing these patients who are always, unfortunately, marginalized, it becomes a fight for both, for the patient to have a safe and a good experience. As I've heard Michelle say many times, the basics is having a healthy baby. Yeah. We shouldn't be acting like
the bare minimum.
That's the bare minimum. It should be, we're trying to, at least even at the birth center, try to marry expectations with reality. But to say, yeah, we just want a healthy baby, but then you're left with trauma, or feeling like you were diminished, dismissed, not heard, and a whole host of other things. But once you get to that point where a patient has to say, I want a good experience. Yes, I want a healthy baby, but I also want a great experience and be able to say I was surrounded by very supportive people who heard me. When you have those representing you and advocating for you, they don't have to look like you, but it makes a grand, big difference knowing that we can understand some of those cultural and social differences and be able to say we're honoring that at the same time.
But why is that such a challenge? Like, why do you feel like it's so hard to even obtain a team that's supposed to have the same goal and just, a healthy birth and just having an overall good experience, no matter where you birth?
We are battling systemic racism. First and foremost, it's literally the foundation of a lot of training, the medical model of care, the history, all of it just kind of falls into play there, unfortunately, when you're dealing with birth in the U.S. And when we don't even see Black bodies as equal 100% of the time, you're going to deal with some issues that could have been prevented. I think, 60% of all morbidity situations could have been prevented.
That's horrible.
When she brings up the Black bodies aspect, which is very concerning as a physician in the field coming up in medical school and residency, to know that even to this day, you'll have individuals who come out of medical school being taught or believe that certain bodies are different than others. Some bodies, particularly Black and Brown, don't experience the same level of pain. So many times I could see, even from interactions on a daily basis, individuals who share that same mentality, whether they're coming from nursing, physicians, or mid-level providers, they will see a patient in pain and go, she's not really, I don't think she really is. And that kind of mindset of believing, no, she's not really, and immediately you're dealing with someone who's not being heard.
Yeah, and that's traumatic. That's traumatic.
But just think of the basis of that, as we said, that's systemic. Mm-hmm. That came from something some years and centuries ago, that it's still playing a role today.
Have you ever experienced that, like, and seen it firsthand?
Absolutely.
Give me an example, Doc.
No.
What have you seen?
No, because they're trying to get me in trouble. No, just kidding. Trying to call me out.
I assume you guys all kind of seen that, right?
Oh, absolutely.
I would love to hear at least an experience where, you know, you felt like, wow, this would have been different if it was, you know?
Right.
I guess we're all treading lightly, but we know.
I'm trying to get the most, the least, out there would be like just not listening to the patient when they're saying, oh, I feel my baby right there. I feel like I need to push. Oh, no, you're okay. Like, we're not picking up contractions. Like, you don't, there's no way you're fully or 10 centimeters, like you just got here. Like just trying to downplay what the mom or the birthing person is feeling in that moment instead of just validating them and just giving, okay, let's see where you are.
Confirming.
And then seconds later, you have a baby in the bed, from people just not listening or paying attention to what the patient is saying.
I know we could be here ad nauseum. I just...
Doc, have you ever had to step in and be like, okay, we're gonna cut the shenanigans here. We're gonna cut this out, all right?
I think we've all had to step in, basically. I think that's why we're here. That's what we do. We are advocates. And then we have to, sometimes I don't think and Michelle can relate, we sometimes don't get to that point where we want to tread lightly because we're seeing something that's blatant and really shouldn't be happening at all to anyone, regardless of who it is. And yet we can see glaring differences when one type of patient says, I'm in pain, can someone give me something? And they go, okay, let's call anesthesia, where I have another situation which actually happened, where a patient waited after declaring I needed something for pain, and that anesthesiologist delayed getting to her because she wanted to give the epidural to another Caucasian woman who came in after the other patient. So my patient sat for 2.5 hours waiting for an epidural that she called for prior to.
Wow.
I can go on, but we're trying to keep this light. And at the same token, know that the fight continues. I think we just do it every day in our work. With everything we do, with our whole entire being.
I think just to kind of add to what Dr. Pemberton was mentioning with regard to situations that arise, that we see truly, epidemic causes of Black maternal mistreatment. Some of it is really just not providing them an experience and choice in the matter. And when you have a delayed situation like, the anesthesiologist not coming into play, there's also just bigger picture things of stuff like not even allowing a person to even have a trial of labor after C-section. And, looking at them immediately and just saying, oh, well, you're a Black person and you come with XYZ risk factors just because you're Black, so we're not going to even allow a trial of labor after C-section. We have to fight for that. Yeah. And a lot of people have to come into, Artemis OBGYN because they were turned away from other providers who just wouldn't even give them the option. And yes, a lot of people come in and go, I want a VBAC. But no, what you want is really the trial of labor after C-section. The VBAC is the after effect of having been successful, right? Yeah. So really kind of helping under people, set themselves up for success in that space is something that we try to do very, very often. And one of my personal experiences that I do want to share is a mom who recently had her 4th baby. And her very first baby she had when she was pretty young. And her doctor, she kind of just gave everything to and listened to everything he said in the moment. And, at 19, she was told for no reason that she needed a C-section.
No.
And so her very first birth, and so that's the problem. When the very first birth starts off with trauma, it's kind of hard to really work on getting, the next births to be the antithesis of that.
Yeah.
And really just sort of working through, and I get to witness, and I love sitting here witnessing this, but Dr. P was like, yeah, we got this. You're going to do this feedback and you're going to get it. And you're going to get all the things that you need. And in that moment, she did. She was successful, but it was with a fight.
It was.
Because there was definitely
going back to that pain management,
an anesthesiologist issue.
No.
Yes. Where this mother had to strip down naked and took everything off of her, all of the bells and whistles, so that someone can actually come into the room to get her pain management, because no one was getting it for her, right? Just really kind of advocating and pushing for herself in those moments. And that's what allowed for that experience to happen. And then
why do doctors turn away Tolacs, like trial of labor after C-section? Why is that not?
I can't speak for their experience, but some people may have had maybe not the greatest experiences. Maybe they were once advocates for women who wanted to have a trial of labor after C-section and maybe experience a complication.
Mm-hmm.
And sometimes those are things that even for physicians or for any practitioners or providers, they experience trauma too. So unfortunately, it could shape the way they practice as a result. You lose a baby, you lose a mom, you have complications that led to, residuals, whether it be physically, emotionally, for that patient can still experience emotional traumas for the practitioner. There's a lot of, and we play, unfortunately, a very dangerous shame and blame game where instead of trying to find ways to learn from those experiences and try to teach our new generations how to practice better medicine, number one, which comes with listening, so that we can actually be preventative towards those potential complications. But two, even if they do happen, even if we've done everything right, not make you feel so. And there are, I know, programs in place to try to find ways to give counseling accordingly, but sometimes that culture still exists in a lot of the hospitals, and people do feel, personally, you'll always feel like I could have done something more and I wish I did something better, and why didn't I see it or catch it? We will always find a way to be our own worst critic. It's worse when you're doing it even inadvertently to undermining or kind of undercurrent to doing it to others. But as a result of it, it can shape the way a physician practices. Others, it's just either business decision, lower risk, it's easier. And again, I'm not speaking for them, but sometimes it's just their practice won't allow it. They'll say, no, we don't. File malpractice insurance won't allow us to, even if we think you're a great candidate, we won't be able to accept you. So there's multiple reasons.
But we see those reasons happening more often with Black bodies.
Unfortunately.
Yeah.
And what are the leading cause of Black maternal mortality? What, at least for you, what some reasons that you guys can think of, other than, I think, bias is one. Do you feel like education also plays, like just even getting as much education as we can get?
Education is key for everything, for the provider to be educated, for the patient to be educated, and in all of those situations. But, back to what Chidera was saying before, it's implicit bias. If you don't care, if you don't have empathy for that individual, then
you're not give them all the options.
You're not going to.
You're not going out of your way.
You're not going to break your neck to go do something.
Yeah.
But we look at postpartum hemorrhage is usually another, phase where it's just not really given the attention and the support that it needs to correct. That's what puts, put our moms in danger.
Yeah, I think we've gotten a lot better over time, but I'm sure in some places and spaces, there's a lot of the times we talk about mortality and women who have, unfortunately, lives cut off too soon were based on delayed diagnoses and management for women who could have been still around if we were able to see it sooner. it starts, and this is the biggest thing for me, it just starts with seeing them as human beings. It doesn't have to be.
That's huge.
Yeah. It doesn't,
Yes.
they don't
Say
have
that
to look
again.
like me to be treated
For the
like
people
For the people in the back.
Yeah.
Like,
It starts that way. That is the basis as far as I'm concerned. That's the foundation, because you can come from any world, any nation. I don't care if you came out of space. From if we see them all, I can't say they're human beings if they came from space, but anyway, but the point is, the thing is, if you're dealing with a woman who is in labor, that's a vulnerable time. And even just the simple respect.
yeah.
You know, when we talk about pain management, we talk about delay of management when it comes to diagnoses and things like that. For me, just simple basic respect, just a modicum of respect. If a woman comes in, I'm about education, whether people believe that or understand that or not. But we should still train our students. When I was in England with the midwives, I had to fight just to see one delivery with the midwife, because they're like, no, you bloody doctors.
Yeah.
You're messing things up, you know? And that's okay. And I had to just show them, I'm really interested in being here. I'm really interested in being here. I'm not here just for show. But they made it very clear, this is a sacred space. And if we understood that even from the MD level, that even when we're training our medical students and our residents, you know, I've seen things still with behaviors that require some significant improvement. You know, just walking in when a woman is at her most vulnerable and she's pushing a baby out, but for the sake of education, I'm going to stand there and go, this is cool. You know, I know it's cool. It's amazing. It's wonderful. But get that woman's permission before she was in that position.
Way before.
Yeah.
You know, and that's basic. Don't wait till she's in pain to say, can I come in and be with the doctor? You have to see them as like, if this was your wife, if that was your sister, you wouldn't even allow it.
Yeah.
So why do you feel you can do it? And then keep training other people to do the same. It just creates that same environment of, they're just bodies.
But it's unfortunate because even as a patient, you feel like this person has all best intentions for you. And I think that's why so many patients are like, sure, if that's what you think is right, let's do it, right? Versus telling your provider or, you know, your anyone like, no, that's not what I wanted. And it's hard. I think, especially me being in a hospital base and I've had that moment where I'm like, no, I'm not doing this. And it's hard to say no when you think these people are your experts, but we also have autonomy in our bodies, you know? And I think not every patient knows that.
Right.
There's a lot of fear.
Yeah.
In it. And, you know, when you hear the news and you hear, you know, the morbidity rates and the mortality rates, you're afraid and you're like, well, they have to have my best interest at heart.
They
so
know.
I will do all the things that you want me to do to make sure that, you know, me and my baby are safe. And sometimes that's not 100% true, right? And so, you know, really kind of being able to parse out like what's real, what's hyperbole, what's an actual issue, and what are you just saying because you want me to be complicit, you know? Like, so there's a lot of...
And we've seen that. I mean, when women start to express that necessary autonomy, when they feel, look, maybe I had a plan, and immediately you see someone go, here we go,
Right.
plan, and then we start talking. That's another culture of believing that immediately when a woman says, I would like to express the things that I would like. And again, that's what I love about Michelle, educating people on making sure you have a proper birth plan, not things that you just get off of the internet, Google, TikTok, whatever it might be. I'm not saying anything negative. What I'm saying is you just be very proactive and educated about even just that. But when you have people say, this is what I would like, can we honor it as much as we can?
Right.
You know, it doesn't mean that everything's going to go exactly. Our goal is to try to bring both together. Again, the basic minimum of healthy baby, healthy mommy. But let's see if we can marry some of the expectations to go with it, with the reality. You'll sometimes see that pushback. And when a woman sometimes expresses
Absolutely.
something that says it was opposite to to what is expected. They're like, oh no, you're not going to do what we say. You're not going to follow through on how. I always joke about it. You hear a lot of people in the hospital. I call it the Montel Jordan, syndrome. They go, this is how we do it. They just keep going. This is how we do it. And I'm going, just because that's how you do it doesn't mean that's always the right way to do it. There's always another way.
Mm-hmm. And that way doesn't necessarily marry with this person.
Correct. Mm-hmm. It shouldn't be a blanketed cookie cutter type attitude. And so that's happened. So when a woman says, oh, I'm going to be someone that's almost like a black sheep, I'm going to stray from this. This is not what I want. And then immediately she starts getting painted in a different light. So now she's what?
Difficult.
Yeah.
Difficult. That's the
word.
word. That's the key word.
That is
difficult.
Immediately. And you could see it's almost like the plague. It's almost like we stayed away from her. So all of a sudden, things that she might request, she might ask for, again, the basic minimums are being delayed, if even given at all.
Ignored.
Yeah. And that's upsetting. And I could see that. And I'm watching and going, oh, okay. Hello, how can I help you?
Like, oh.
Yeah.
And also let's talk a little bit about what it looks like for partners. So we're talking about Black maternal health. And what does that look like for the Black men in these women's lives and how they're treated in the birth space? And sometimes their voices are totally not heard and they're dismissed. And oftentimes they're seen as a threat in the space.
Aggressive.
And usually are threatened with being told to leave the birth space. I mean, can you imagine being told to leave the sacred space of your own birth?
Yeah.
Your baby's birth. Like, that's just crazy.
Yeah, things tend to escalate when they say, I'm going to be my wife's advocate. Yeah. And all of a sudden, it's like, let's call security.
Yeah, security comes in.
I cannot.
And it's, that's another piece of it. Like, she can't have support. Like, you don't want her to have support. I was in a birth space also. I came in during an induction, so I'm usually not there at the beginning. So I came in a little bit later. And I walked in and I started just kind of call the nurse button and started to say, I looked at the room and I saw some things were just not the way they should have been. And I was like, hey, can she have this? Can she have that? Can she have this? I could hear as soon as the thing went off, they're like, oh God, she's a doula.
No.
Right? And then all of a sudden it was just kind of like, okay, now we have to
do our job.
Now we have to do our jobs. Yeah.
Oh man. Why have Black midwives historically been so crucial to qualify in maternal health care?
Qualify how? I think the biggest thing, actually, that's a good question, because even in my class, there was only 2 of us. So,
wow.
That says a lot in itself. I feel like just being a Black person in general, you have to fight twice as hard to get half of what others seemingly get just by showing up.
Existing.
So that plays a part. Finances, as far as economic class, and funding half of these programs are very expensive. Those things kind of create a barrier for us to be the next step where we become the provider, where we're also, a safe space or a safe face that kind of looks like the patient to help provide. Because, having a provider that's just culturally competent in general is amazing. But having someone who looks like you says a lot, because there's things that you can relate on that not everyone can, see, that changes the outcome in the way the birth progresses.
And we get that a lot with a lot of patients who are like, I really want a provider who looks like me. And that says a lot. Like, I honestly, I feel sometimes like I hear the trauma once they say that. Like, I hear it and I'm like, wow.
Well, they want to be seen. They weren't seen before. They want to be heard, and they want people to respect who they are.
Right. But they don't feel like they have to explain or go out of their way to, I don't know, rationalize, apologize,
There's
whatever
a
it might
level
be.
of comfort, because, we can code switch.
Quick.
Right? We know exactly what it means, like how to,
Hello.
we get in our space. But, to be able to just be yourself, it's like now I've just truly exhaled.
Yeah.
And if I'm in a space with providers who look like me, then I can
be
clown
myself.
And
Yeah. But you tend to get more, as a practitioner, I'm sure Shadera can understand this, and then Michelle as well. People tend to be more open with some of the things, the fears that they have, the concerns, things that we can actually address
because
in those moments
relate.
before the birth happens. And we can be able to bring a lot of those things to light and be able to have conversations about it, address them. So I find ways to use it as a means of equipping them with what they need when the time comes, or educating them to certain things that they may not have been as well, prepared for. It gives us that sense as practitioners as, well, we know this patient, she has these concerns, and we want to make sure that we can be able to say we are, understanding specifically it's not ideal to say we can have all the details on every patient, but when those patients feel that level of comfort, you will find they're not holding back as much.
The clenched fist.
Yeah. And just, very, I'm going to say what I need to say, and I'm going to try and see if they hear me or don't hear me, but immediately can shut down when they just feel like they didn't get what they were looking for. Coming in and seeing that and going, okay, I got so much to tell you. And then we're like, okay. No,
How do you think we can solve this crisis?
Listening to mothers, like literally, like allowing them to have choice, to have autonomy, like all the things I said at the beginning, right? Like really seeing them for who they are and trusting that they understand what they want. Mm-hmm. Right? Because sometimes there's like this whole inflection of, no, like you don't know what you want, and I'm going to do what,
right. I'm going to tell you.
I'm going to tell you what you're going to do. And
but even equality, right? Like just treating every patient the same. Not in the same, but more so like treating a patient as a human.
Right.
Like if I say I'm in pain, I would want you to take my word for, hey, I can't tolerate this pain.
Right.
And you're acting upon it.
And then also appreciating, like you could say, I'm in pain, I don't think I can tolerate it, walking into the room and saying, I'm here to give you an epidural, and they go, you know what? I don't think I want it anymore. Yeah. And now I could be like, she changed her mind. That is her choice.
It's okay to change her mind.
It's okay.
Yeah.
And she shouldn't have to feel bad for that, because other people know what that feels like when it comes to having choice. And being able to say, I can change my mind in a heartbeat. No one should be made to feel a certain way when that time comes.
So aside from education, aside from listening, I think the way we're going to solve this is making providers accountable for their actions. When you don't get in trouble for not listening and not paying attention and not supporting Black and brown bodies, then you're going to just keep doing it.
Yeah.
And you're going to keep repeating the cycle. You're not going to see the harm that you're doing. Maybe you see it and you don't care.
Right.
Whatever it is, like you're not, if you're not held accountable for your actions, then we're never going to solve this crisis.
And that's what scares me sometimes, because that's really systemic, because we've seen on levels outside of medicine when we've harmed families, when it came to just from a legal standpoint, when we harmed families with traffic stops, and those individuals' lives were completely uprooted, and individuals who were responsible for that didn't reap any consequences for it. So, I don't want it to make it seem like the answer to everything is punitive. No, it shouldn't be. But it is a concern on every level. I think it's still a concern, because you want to look for people to find the goodness of their heart, but you hoped that when they went into healthcare, that was what they were leading with in the first place. Somehow we lost our step, just forgot that no matter who you treat, no matter who you care for, everyone, the only time I believe in the cookie cutter mindset is if it means treating everybody like a human being.
Yeah. Oh, true. Well, it was a pleasure speaking to you, ladies. I appreciate your time, especially Doc coming from a birth. Shadira coming from a birth.
And Michelle coming
from a birth. Everyone had a birth today, which is great.
Birth happens. That's the birth blueprint.
Thank you, guys.
Thank you again for joining us. We'll see you again next time. Be sure to leave suggestions and comments. Check out our Instagram. We're on Apple Podcasts and Spotify, and we'll see you next time.
Woohoo!